First, I'd like to introduce Dr. Audra Langley. Audra is an assistant clinical professor in the Division of Child and Adolescent Psychiatry here at the UCLA Semel Institute for Neuroscience and Human Behavior. She is also the Director of Training for the Trauma Services Adaptation Center for Resiliency, Hope, and Wellness in Schools, and serves as chair of our NCTSN Schools Committee. She is a clinician and researcher who specializes in cognitive behavioral treatment for children and adolescents with PTSD, anxiety, and other related disorders. Audra received her PhD in clinical child psychology from Virginia Tech and went on to specialize in CBT with children and adolescents. She's currently a faculty member here at the UCLA Child OCD, Anxiety, and Tic Disorders program. Welcome, Audra. Our second presenter today is Eugene Thompson. Mr. Thompson has coordinated the development of 2 SAMHSA-funded Systems of Care grant applications. The first was Worcester's Communities of Care, which piloted a high-fidelity wraparound model for youth with serious emotional behavioral challenges, and Central Massachusetts Communities of Care, which focuses on diverting youth with emotional behavioral disorder issues from juvenile justice involvement. On both projects, Mr. Thompson oversaw training activities, which included being directly responsible for implementing evidence-based practices, including positive behavioral interventions and supports, and trauma-focused CBT. In October 2009, Mr. Thompson was awarded a second SAMHSA grant in which he serves in a supervisory capacity in trauma-focused CBT at the Central Massachusetts Child Trauma Center. Mr. Thompson is currently employed by the University of Massachusetts Medical School. Welcome, Gene.
Yes.
Our third presenter today is Judith Thompson. Judy is the coordinator of counseling psychology and community outreach services for the Worcester Public Schools. She worked for many years as a school psychologist, providing services across the preschool through high school levels and in special education programs. Currently, she supervises the professional activities of the school adjustment counselors, social workers, and school psychologists in the Worcester Public Schools. The school district's Positive Behavioral Intervention and Support Initiative, PBIS, has continued to grow with her support and direction and is considered to be exemplary within Massachusetts. She has taught graduate-level courses in child and adolescent development and school, family, and community involvement, as well as providing numerous staff development programs within the Worcester Public Schools. Welcome, Judy.
Thank you.
Last but not least, our final presenter today is Dr. Jennifer Axelrod. Jennifer is a manager for Chicago Public Schools in the Office of Special Education and School Health Division. Jennifer focuses on the integration of services for children at risk for social, emotional, and academic difficulties. Jennifer also works to create linkages to the school mental health professional community and supports the professional development of teachers and school mental health staff. Previously, Jennifer worked at CASEL, the Collaborative for Academic, Social, and Emotional Learning, to support the implementation of universal classroom-based SEL programming. Jennifer received her master's in school psychology from the University of North Carolina at Chapel Hill and her doctorate in school psychology from the University of Georgia. Prior to joining CASEL, she was an assistant professor at the University of Maryland School of Medicine and the associate director of the Center for School Mental Health Assistance. She is also a licensed psychologist and a nationally certified school psychologist. Thank you, Jennifer. Welcome. I would now like to hand the webinar over to Dr. Audra Langley, who would also like to welcome our audience today and preview today's presentation.
Hi, good afternoon, everyone. I'd like to welcome everyone to today's webinar again, and just let you know that it's our hope that you'll find the information today beneficial to the important work that each of you do every day. First, Gene Thompson will be talking primarily at a more macro implementation may have been proven to be effective by its developers in its original setting, but is it being implemented effectively in its new and current setting to ensure fidelity to the original model? Next, Judy Thompson will provide a brief overview of the Response to Intervention, or RTI, framework used in schools to support academic learning, and she'll also describe parallels between RTI and Positive Behavioral Interventions and Supports, or PBIS. Judy will share examples of PBIS implementation to illustrate how this school-wide approach benefits students and leads to improved systemic coordination to enhance the mental health of students through partnerships with families and also community-based service providers. And then Jennifer Axelrod will be providing an overview of the implementation of evidence-based Tier 2 interventions, including cognitive behavioral intervention for trauma in schools in a large urban school district. She will share successes and challenges of implementing these practices and review strategies for improving implementation fidelity. Thank you very much to everyone for taking the time to be with us today, and I'll now hand the presentation over to Jean.
Thank you, Audra. First of all, I want to acknowledge what an amazing entity I have found the National Child Traumatic Stress Network to be, and especially I want to thank the school committee, which is chaired by Audra Langley, for putting the speaker series together. As you've heard and surmised, my experience is largely that of a behavior health administrator. And for the last 11 years, I've been part of a project team that has operated as a laboratory of sorts. We've been conducting demonstration projects, evaluating them, and then disseminating what we've learned regarding a series of evidence-based practices by providing extensive training and technical assistance at the end of each of these pilots. For example, the first was high-fidelity wraparound. After roughly a decade of work, I'm happy to say that we've helped to pilot and then implement a version of wraparound that now extends across Massachusetts for all Medicaid-eligible children with complex emotional and behavioral challenges. In a separate pilot, we also have trained and sustained teams of clinicians operating at multiple outpatient mental health clinics, teams that now provide trauma-focused cognitive behavioral therapy. This is a clinical model for the treatment of childhood trauma that has an impressive amount of evidence that documents its effectiveness. And the third major project for us has been over the years implementing positive behavioral interventions and supports, which is also known as school-wide positive behavior supports. They're the same thing. It's a framework you'll be hearing more about from the next two presenters, so I won't say too much more at this point. We have implemented PBIS in about 60 schools from about 15 separate school districts in central Massachusetts, working in partnership with Worcester Public Schools, the Massachusetts Department of Elementary and Secondary Education, and the National PBIS Center, which is operated by George Sagai. I'll be talking more about him later. So for the next few minutes, I'd like to talk about what contributes to effective evidence-based practice implementation, with the emphasis on implementation. To paraphrase Dean Dixon, who's an implementation guru, quote, "It is one thing to have an effective evidence-based practice. It is quite another to have an effective evidence-based implementation of that practice. Both are necessary to achieve fidelity to the model." So as a first step, I thought I would have you look at what I think is the way in which much training is conducted in schools and elsewhere. Kelly, if I could have the next slide, please.
Okay.
I trust everyone on this call has received training that exemplifies what George Sagai calls the train and hope approach. The original concept comes from an article by Stokes and Bayer that they did in 1977. This is George's diagram. George is one of the co-founders of Positive Behavioral Interventions and Supports and co-director of the National PBIS Center, along with his colleague and co-founder, Rob Horner. So starting at the top of this diagram at about 11 o'clock, a new problem is encountered. The systems then react to the problem. Potential evidence-based practices training binder, but sometimes you have to buy supplemental materials after the initial workshop. Then the experts leave, and there's a general hope or expectation that administrators, teachers, everyone will somehow implement and internalize the new practice. Then a new problem emerges, and the cycle's repeated, usually without ever implementing the new practice with fidelity. I suspect that sounds familiar to many of you who've been in the field for a while. So the question is, what does implementation experience in literature suggest is a better way? Kelly, next slide, please.
Okay.
There really is a fair amount of literature now. The science and art of implementation has had a lot of work in the last decade. Many sources on the topic of effective implementation, but my personal favorites are Dean Fixen, Fixsen. His name appears at the bottom of this slide, and George Sugai. You can access much of their material, presentations, PowerPoint presentations, etc., on the TVIS site, which is www.tvis.org, which also appears on the slide. Or you can just Google their names, and a lot of material will emerge. Gleaned from my personal experience and this literature and these two teachers, mentors, I just want to make three fundamental points, which are highlighted above. The first, to fully implement any evidence-based practice, for example, PBIS, with fidelity to that model, typically takes about 2 to 3 years with coordinated training, coaching, and supervision. Now, the emphasis there is with fidelity to the model, because clearly a lot of folks don't follow this format. But if you really want to get to the point where you have fidelity to the model, it takes that period of time. So, yes, you should bring in experts, absolutely. But start immediately to grow your own coaches, leadership teams, kind of internal experts. This is because the experts are expensive. They're not always accessible for the ongoing coaching and support. And now most of the mature evidence-based practices, ones that have been around for a while, conduct train-the-trainer series to assure sustainability and to develop local training capacity. That's built into the TBIS implementation model. They have workbooks to train coaches. They have workbooks to train leadership teams, district strategies, etc. When I first approached George Sugai for assistance 5 years ago for the second wave of PBIS implementation, he said, "I'll agree to provide training and consultation on one condition, that I start training my replacement on day one." We did that and now have a cadre of local and regional trainers. George is still involved, but he doesn't do any of the direct training. He's much more consulting and helping us work at the state and regional level. The second point is to set and limit your priorities. Most schools really can't take on and effectively implement more than 2 or 3 new initiatives at a time. Even 2 or 3, if they're complex frameworks, can be a real challenge, but certainly no more than that. If your school is already implementing responsive classroom, literacy and math, evidence-based practices, and anti-bullying curriculum, it's probably not a good time to take on another systems change like PBIS or anything else. The third point is that senior administrative participation and support is essential for successful implementation. I think administrative buy-in is probably the single most important variable and predictor of success or failure in implementing any evidence-based practice. It's not sufficient by itself, but it's really critical for successful implementation. Most states, looking at CBIS as an example, most states require written commitments to this effect by school and district administrators prior to giving an award or permission to participate in CBIS training. And it's not unusual for school leadership teams to be turned away from training events if they show up without an administrator on on the team of participants that's come to be trained. And that's actually our practice in Central Mass, too. There has to be an administrator on the team. So this has been a very brief presentation. We're going to have a question and answer session at the end of the presentation, but please feel free to contact me if you want to follow up on anything I mentioned here today. My email address is on the second slide of this presentation. So now we'll hear from Judy Thompson. She's really been my partner in this venture in the Worcester, Massachusetts area, and she's from the Worcester Public Schools.
Thanks, Gene. Yes, we've been partners in crime in some of these revolutionary ventures with mostly good results and lots of learning along the way and lots of challenges. Thank you very much. And I don't know today how many school folks are on the line and how many mental health folks are on the line. And I hesitate because I don't want to bore either group. But I'm going to talk a little bit initially about RTI and how it developed. RTI, as Gene referenced, stands for Response to Intervention. And it's an approach that's developed in schools, has become in favor across education, partly, probably, in reaction to older and less effective and less efficient decision-making models of intervention for students who struggle in their academic progress. Partly because of the way that laws governing special education processes are configured. In the past, students were often required to fail up in order to qualify for extra needed services. The laws require a demonstration of need based on the existence and the impact of a disability, and the impact has to be demonstrated to be significant to prevent effective progress in the curriculum. In some ways, insurance requirements mirror that in some ways when specific diagnoses are required or certain medical necessity criteria must be met in order to qualify for certain mental health services. With few exceptions, additional help for learners, students who are struggling, was not available unless they qualified for special education. Yes, there were some other supplemental programs. There were things like reading recovery and there are Title I services. But on the whole, the monitoring was not that frequent to see who needed those interventions. And kids would be doing really badly and often seriously lagging in their academic progress as compared to peers of the same age before extra supports were provided. Now, this model was never terribly effective. When you only do progress monitoring annually or semi-annually, it's like we wait to the end of the year to decide if you're going to be promoted to the next grade. That's not very rigorous or frequent monitoring of progress. So it makes a lot of sense to be looking more frequently at progress and intervening earlier if a student's struggling academically. And with the increasing diversity of needs, with increasing diversity in our population, in Worcester, Mass, we are a school district of about 24,000 students. We're at about a level of 72% free and reduced lunch, which is our socioeconomic indicator of kids whose families are struggling with the issues of poverty. There's over 100 different languages spoken in the homes of our students. We are sort of, have always been, Worcester has always been a place where lots of immigrants come to. And the richness of diversity is a really cool aspect of our school district, but it also brings us many, many challenges. I'm sure Chicago, being much larger, you hear from Jennifer in a few minutes, has even greater challenges given just the size alone. But that's in a nutshell what Worcester looks like. So with the diversity of our students coming into us, this old model of giving extra help once kids fall far enough behind was just not making any sense. Teachers need to be able to diversify instruction earlier on in order to address the particular learning needs. Some kids need repeated or differentiated instruction to master some aspects of skill or content. And then when you have No Child Left Behind come along with an increased emphasis in the field on the fact that all students need to achieve goals that indicate high levels of academic proficiency, new approaches were absolutely needed that focused on preventing failure through an approach that embodies more proactive support and continuous monitoring of skills. And that's pretty much what you have. In response to intervention, the response to intervention approach emphasizes high-quality practices and certain essential core principles or essential beliefs. Those beliefs are that all children can learn when taught with effective practices, that early intervention for kids who struggle is essential, that we need a multi-tiered model of service delivery to address all needs, and that we have to be continuously collecting data and adopting a problem-solving methodology. Have you got my core features slide up there, Kelly?
Yes, we do.
Okay, so you see in there some core features that embody some of those basic principles I just mentioned. The investment in prevention, universal screening, because kids don't even enter the kindergarten door with the same level of readiness for academic learning. So we need to be screening everybody. We need to be intervening early and providing those supports that are required in order for kids to have the readiness. We need prevention-based, problem-solving, using data at every step of the way, and research-based practices, with some individualizing when we need to tailor an intervention to the specific needs of a kid. We can go on to the next slide now, where you have the triangle, and Kelly uses a similar triangle in a little bit different way. But here you see, on this next triangle, the parallel academic system of RTI intervention and the PBIS system in terms. Now, to buy into the whole idea of a PBIS model, there needs to be an awareness and a buy-in in schools that we can't assume that kids know how to behave when they come through the front door. Maybe in certain communities at one time when you had a more homogeneous population, when all the families were pretty much holding up similar norms of expected behavior in their homes, there was less need for this sort of awareness. But the fact is that many of our kids come to school from such diverse backgrounds that we can't make those assumptions that they know how to behave. And it's not a problem because we're educators, so we can teach. But what PBIS assumes is that we understand that there's a need to teach expected behavior. And as we do with many academic skills and many other important skills, some things need to be taught and retaught. And sometimes they need to be practiced and modeled, and kids need reminders to use the new skills that they are learning through that teaching. So you see we have in this triangle 3 tiers of intervention. And I think that this sets up the possibility of engineering an environment in school where positive behavioral development is being shaped for all the students, and this has particular advantages for kids with mental health issues, for kids with a history of trauma or other sort of adverse circumstance in their background. So looking at these, you see how in all 3 tiers we have universal interventions which are applied to all settings, all students. These are preventive and proactive, and we'll talk a little bit more what those look like in a few minutes. You have secondary interventions for some students. The philosophy behind this is the same as the public health triangle that you see in used in many other ways, with consistent, clear expectations being taught in all settings, across all staff, with acknowledgement of expected behavior when we see it. 80 to 90% of the students are going to function successfully nearly all the time. A smaller group of students who we will say rise to a tier 2 level of needing a secondary intervention need a little more support to master those skills. They might need more attention. They might need more reinforcement, more shaping. And a very small number of students will rise to an even higher level where they need very specific, individualized, or sometimes they need multiple tier 2 interventions. And in Worcester, we frequently work with the families of these students in the wraparound sort of fashion that Gene talked about that he brought in through the mental health side of things. We can go on to the next slide here. And this slide didn't come out exactly perfectly. It got a little bit squashed somewhere along the way to the merger here. But on this slide, what we have is a closer look just at the positive behavior interventions and supports model, because what PBIS is a response to intervention process applied to the learning of social and emotional skills and the learning of behavior. So here, what we see is that we've got, the triangle's been flipped over, so we have universal at the top, school-wide assessment, school-wide prevention systems. This, again, would be the establishment of 3 to 5 expectations for behavior. We stay away from negatives. We don't post rules that look like no hats, no running, no swearing, no gum chewing. We post rules that look like be responsible, be safe, be ready to learn. Be responsible, be respectful, be safe, and be ready. A lot of our schools, once they've made their decision to adopt this model, they go through their own debates internally and they decide what's the language appropriate to our school to communicate these expectations to kids, and many of them come up with something that looks like responsible, respectful, safe, and ready to learn. Those expectations are posted throughout the school. They are taught and they are operationalized in specific settings, such as what does safe behavior look like in the hallway? It looks like we walk. It looks like we maintain a touch-free zone. It looks like we use indoor voices. What does respectful behavior look like in the lunch line, and so on. So there's a specific focus on the teaching of expected skills at that universal level. And it's one of the biggest things is getting all the adults in the building to agree and to adopt similar criteria for how they're going to teach these behaviors. We have some tools like the school-wide implementation checklist, the school-wide, the team implementation checklist, the school-wide assessment tool and action planning tools to help schools to get their universal system up and running. At Tier 2, secondary, this will be the kids who, based on data, and the data that we're going to look like are the office discipline referrals. Some kids, in spite of that school-wide approach, are going to show up in the data with more frequent office discipline referrals in spite of consistency and the clarity. This is assuming you've got a pretty good implementation there on the part of all the adults in the school. We're going to look at their attendance data, their tardies, their grades, as well as academic progress. How are they doing in terms of acquiring academic skills? There'll be some looking into whether some of these kids, when they're being considered at a Tier 2, when we have that targeted team process, and Jennifer's going to zone in much more specifically on interventions that happen at Tier 2 in Chicago. But there may be some social skill backup. We have a large implementation of Second Step in many of our schools and another program called Steps to Respect, which are very much in vogue in terms of anti-bullying and in terms of general social emotional learning. But some of these Tier 2 kids may need some of those skills that are taught in Second Step, pre-taught or retaught to them in small group settings with some of our school adjustment counselors. So we make interventions of that sort for some of these kids who continue to show that they need more practice and more exposure to expected skills. We may put some of these kids on a check-in, check-out system, which means that a mentoring sort of relationship is established between that student and someone on the school staff. Very important question we'll ask at the targeted level is who likes this student? Who likes this kid and could form a helpful relationship with them? And maybe the student ends up with a schedule of 3 times a day they're touching base with that person, and that person becomes kind of their special individual behavior coach. How did that last class go? You got everything you need for the next class. Or even, especially important with some of these students, greeting them in the morning to see how do they look upon entry to school. Do they look like they slept well? Do they look disheveled or like they're sick or like they were in a fight on the way to school? Did they have breakfast? Why do we set these kids up to have a bad day when we know these are kids who are needing more support? If we see them step in the front door and we know something's up, maybe they got no sleep last night for some reason or other, let's take them to one side and address the need before they go in and possibly have a triggering experience when a pencil breaks and lose that day for academic purposes. So again, it's about being aware of the data we need to collect, and sometimes that's pure observational data. How does that student look at the first thing in the morning? And then being proactive and doing the things that are preventive. We always think if we can predict it, we can prevent it in a PBIS school. So it's about using data proactively to prevent problems from developing. Kids who need even more support than that may graduate up to a Tier 3 intervention. And again, that might incorporate some interventions that are already in place from Tier 2 that are having some effect but are not sufficient by themselves. We may end up getting into a full-blown functional behavior assessment to try to determine if we can't determine what is motivating, what's driving that behavior or maintaining that problem behavior. And in Worcester, we frequently will be looking into are there possibly some family needs going on. Very, very frequently there are. We have a growing homeless population. Many families that are struggling with issues of mental health on the part of a different family member, or with homelessness, or with serious domestic violence. Dealing only with the student is not going to resolve what is contributing to the chaos that child may be bringing into school, and that's undermining their ability to be effective. If we go to the next slide, this slide breaks down some of what I started to talk about before as far as the primary prevention parts of the school-wide focus. What does this look like on the ground in the school? Having the school achieve a consensus around 3 to 5 expectations that can be stated efficiently in a way that's appropriate to the culture of that school, and they adopt some plans to teach that expected behavior to everyone. So there's no harm in reviewing some of these things. They're good reminders for kids. There's a commonly agreed upon approach to discipline. This is a big one in schools. We frequently, especially when we're training up schools new in this, sometimes we have to convince them that they don't have perfect consistency in the way they're following expectations. Often if we talk to a school principal about, are the discipline referrals coming in from your teachers in equal numbers? Or do some teachers hardly ever have a student sent to the office for discipline problems, and others have many? And generally, in a school that hasn't been targeting their own consistency, we'll see quite a lot of that. There'll be quite a lot of variation. So having the faculty and the principal get on the same page as far as the criteria for a referral to the office, which behaviors are expected to be managed in the classroom and which are expected to be managed to the office. We still have some situations come up where a teacher, typically a secondary level teacher, may expect that any student who comes to class without a pencil should get sent to the office. Most of the time, principals love hearing that we're going to bring in the idea that, there should be some equity in the way discipline is distributed. Even when you have 6 or 7 different teachers teaching each student in a large secondary setting, there needs to be some consistency. So pencils, we don't send people to the office for not having a pencil. However, a fight breaks out or something, yes, we want that referred to the office and so forth. So getting the grown-ups to come to a consensus and then developing a rubric for what does this expected behavior look like in the different areas, the different times in the school schedule, and then encouraging the expected behavior when you see it. There's such a thing as reinforcing that behavior. So saying more frequently, good job to kids. Often in schools, people fall into the habit of only paying attention to the student who's acting out of order. And so this means sort of switching the lens for some folks in education and saying, we're going to look for the kids who are doing the right thing and tell them, good job, or I like the way you're doing that, or I appreciate the way everybody's paying attention right now. And the more you use that sort of verbal feedback, the less you have to give negative corrective feedback. There are procedures in place for discouraging inappropriate behavior. Sometimes that has to do with the deployment of staff attention, often in non-structured areas of the school. We'll get into that a little bit more. But there are also some clear procedures for data collection to evaluate and monitor. And you have a universal team that's responsible for that school-wide implementation, that meets regularly, that reviews data to start every meeting, so that they have a handle on where and when are our problems occurring. How do we know where to address problems if we don't know when and where and with whom, in what situations are these problems occurring? So there's an active effort to get a data collection system that's feasible and that can be implemented with some fidelity. Next slide there, Kelly. Classroom setting features, is that the one we're on?
Yep.
Okay. In the classroom, what does this look like? There would be a posting of some classroom expectations, and these are taught, reviewed regularly, and reinforced in the classroom. We encourage teachers to maximize the structure in their classroom. Maximizing structure means establishing routines, and it actually ends up lending itself to more time for instructional objectives to be achieved, more instructional minutes when you maximize structure. A lot of our principals and a lot of our schools are emphasizing bell-to-bell teaching. If you have secondary schools, middle schools, or high schools where kids are changing class every 45 or 50 minutes to go into a new period, that transition time can lead to a loss of instructional time if it takes a few minutes for everybody to get settled in. So maximizing structure often means having a routine established in that classroom. Students enter the classroom and they know there's an assignment on the board. They know that they're supposed to, for example, sit down, put their homework on the right-hand corner of the desk, and begin doing the assignment that's up on the board. The teacher circulates for the first several minutes, makes a note of who has their homework completed, and then they get into the lesson from there. But it minimizes the lost time for transitions if you have that sort of a routine that's established. And again, the consistency and the clarity for kids with a trauma history, this becomes sort of a benchmark, a stronghold for their own sense of security. It's that consistency that can build a sense of safety in that school environment, especially important in larger secondary settings. Actively engaging the students in observable ways. This is a real pitch for engaging academic lessons for kids. College lectures are not going to work when we're talking about K through 12 education. Acknowledging appropriate behavior sends that message to all the kids in the classroom. Oh, this is what they want to see. Okay, I can do that. And establishing a continuum of strategies to respond to inappropriate behavior. At the lowest level, little nonsensical behavior, there may be some deliberate ignoring, some deliberate attending to the kids doing the right thing. That's one end of the continuum, all the way up to the other end of the continuum, where maybe the student does have to be referred to the office, but with whatever documentation we're using to collect that data. Go to the next slide, Kelly, non-classroom settings. Positive expectations are taught and encouraged in non-classroom settings, in the hallways, in the cafeteria, at dismissal, before school time. These are very parts of the school day because they go a long way to establishing the tone and the culture of the school. When non-classroom settings are more orderly, less chaos is spilling into the classroom and potentially disrupting that lesson getting underway. Teaching the expectations for lunch behavior, recess behavior, bathroom behavior, passing in the hallways, dismissal, and so on. If we look at the non-classroom setting points, positive expectations are taught and encouraged in all those settings. Routines are taught and practiced. All staff are supervising, scanning, moving, interacting. This often means that the message, and the message usually, in a PBIS building, what we've learned is administrators need to be comfortable with a distributed leadership model to implement this in their buildings, because the universal team will share some of the decision-making power for how we're going to implement this universal strategy. And so if they want to make rules for all teachers in the school, all staff will stand beside their classroom doorway during the passing periods. Some teachers aren't going to like that unless you've gotten a buy-in across the board. But having all staff supervising, scanning, moving, and interacting, we know that teacher supervision is one of the most powerful tools we have. We want to make sure we're deploying it for maximum efficiency and effectiveness, using pre-corrections and reminders as prevention. Kids will need cues. They're not done yet growing up. Positively reinforcing that behavior that we want to continue. Addressing individual needs, and I know that Jennifer's going to get much more into that in Worcester. And this is where we use what's called a student support process in our system. You see the SSP on that slide. Decisions are made by a team. Sometimes it's the SSP. Some of our PBIS schools have a separate. They use at the SSP level. They look more purely at academic issues, and their targeted intervention team may look at the behavioral issues. But there's a targeted team process in place with social skills and self-management instruction being an expectation. That targeted team is going to be looking at accurate and relevant data. They'll be providing social skills. They'll be providing individualized accommodations. Frequently, at the targeted and intensive level is where we're engaging community-based folks We've got some formalized linkages with mental health providers of about 7 or 8 different agencies, as well as with our public agencies, our DMH and Child Welfare. The school adjustment counselors in our system also are the supervisors of attendance. We don't have truancy officers in Worcester, and so we've got some very well articulated relationships with juvenile probation and the clerk's office and the judges as well, to try to make sure we're adopting as much as possible kind of a strengths-based approach, but also a reality-based approach that says, listen, this is the law, you need to be in school. So we try to use individualized accommodations as needed. We look at function-based support for behavior intervention. What are the needs behind this behavior? And we may use intensive, multiple targeted group interventions or strengths-based family wraparound. The needs of some students are directly linked to family needs. The needs of some students are related to academic needs. And these families, because they frequently perceive schools as blaming and shaming them for the challenges that their kids may have that may be related to mental health issues, we need to overcome that perception. That takes a lot of concerted effort on the part of school folks to overcome and develop a partnership with families that says, we really do want to help. My last slide there talks about some of the similarities in practices and values and processes. Basically, the PBIS approach within schools is a strengths-based approach. It's designed to build on the strengths of the individual. A lot of the time before we roll out with a school, when we're training them in PBIS, we'll hear school staff say, so-and-so, that kid, he's going to end up being a targeted kid. And very frequently, once the universal implementation is rolled out, some of those kids don't need targeted interventions. They respond to the clarity and consistency and positive tone and reinforcement for expected behavior that's at the universal level. So some of the kids that school staff may think, those kids are going to need more help, actually, all they really need is that clarity and consistency across all settings, and they're going to do fine. But there will be those kids who come up to the next level, and there'll be those kids who graduate to needing a tertiary level of support. But I think that the use of a PBIS system within schools sets us up. It's a much stronger framework for our integration of mental health supports in school, for collaboration with treatment providers and trying to make sure that we're all on the same page. And it's the basis of a shared agenda with families, as well as treatment providers and other segments of the child and family serving macro system that Jean was talking about. That's when we all are pulling together in the same direction. Services can be better coordinated and even integrated, mutually supportive. Families can be less confused and better able to focus their efforts effectively, and all of that can lead to much better outcomes. I think it's important to always remember that Tier 2 and Tier 3 interventions are anchored in Tier 1 interventions and are natural extensions and basically intensified versions of Tier 1. But again, it's a strengths-based process, and I think when we activate the strengths that every student brings with them and the strengths of their family and the resources that the community can bring to the table, we can all be much more effective. So with that, I think we're going to turn it over to Jennifer next, who's going to look much more closely at the Tier 2 interventions they've developed in Chicago.
Thanks. I never have been set up to talk quite as nicely as I have by the two presenters who came before me, because I think they've done a nice job of establishing what are really critical foundation pieces before we start talking about what are those Tier 2 and Tier 3 interventions for students. Very briefly, I just want to talk to you a little bit about coordinated school health, so we'll go to the next slide, shall we? Coordinated school health is housed within the Office of Special Education and Support. We are responsible for a number of different supports and services that we provide to students in public schools. For those of you who may not be familiar with Chicago, just a couple of quick demographic information. As Judy mentioned, we are a little bit larger, but that doesn't mean the issues are probably any different. We have about 675 schools, over 400,000 students. 86% of our students are from low-income families, and roughly 13% are limited language proficient. And so we come at this work with two issues. One, what does it mean to do this work in a large urban district, and how do we sustain this work and scale it up so that when we know we're doing it with fidelity? Within coordinated school health, we look at really what the whole child is. As Judy mentioned, you can't do this work independent of the other factors that are going on in a child's life. So some of the areas that we focus on, in addition to the behavioral health supports, are is a child in medical compliance, because they're not going to be in school if they don't have their immunizations. Can they see? A lot of our kids have a very difficult time getting access to vision services, so we provide vision services and glasses for a number of our students. It's amazing how when you can see, it cuts down on your behavior problems in the classroom. We also provide dental care for all the students, pre-K through 8th grade, so that's a free service that all of our students can access. In addition, we do a lot of outreach because we know that within our district we cannot provide this alone. We have to link to our community agency partners. We do that very strategically so that we can make sure that our families have the best access to care that we can provide. And we also provide crisis intervention services so that for those folks who are those schools that have, unfortunately, maybe a suicide or a shooting or a death of a staff member, we do have resources available to help with that. And unfortunately, that's all too common in our schools, so that's great to deployed out there. Next slide, please. I'm not going to spend really any time talking about this slide because Judy did a wonderful job referencing it. I think where Chicago is, and maybe others on this phone call are, is we wish our triangle looked like this. I think right now we could probably flip it upside down because we're still working really hard on getting those universal strategies out there, those consistent practices across the 675 schools. Until we do that, we wind up with so many more kids in Tier 2 and Tier 3. Because as Judy said, they're not getting what they need at that basic level, that there are clear expectations, that they know how to behave, that they're being taught and retaught those expectations. And so when I show this slide to folks in CPS and I say, well, about 1 to 5% of your kids need intensive intervention, they kind of look at me like, really? I don't think so. And that, in reality, is because our kids are so highly stressed, a lot more of our kids do need Tier 2 and Tier 3 support as we build that Tier 1 structure out. Next slide. Just wanted to give you a glimpse of some of the strategies that we're using within CPS to try and build out a lot of these supports. We're going to spend the majority of our time together today talking about the targeted interventions and how we've started to really infuse those evidence-based practices. That just to give you an idea that those do not exist in isolation, and again, a lot of these are going to be very similar to what you just saw. At that prevention level, we are talking about what are those school-wide expectations look like, those common expectations and values. And with that, we're also layering in that explicit instruction on social emotional learning and skills. Because our kids often aren't being taught range of feeling vocabularies. What is empathy? What is problem solving? What is impulse control? In addition to teaching them what does it look like in the classroom, we want to make sure they have explicit instruction on how they can actually demonstrate those skills. Oftentimes when I'm working with kids, especially little kids, they'll have a very limited range of feeling words. So I'll say, well, that's how they'll feel. And many of you, I'm sure, have had this experience as well. They'll say happy, mad, or sad. And sometimes you won't even get sad. Sad is usually mad. And so how do we give our kids a better feeling vocabulary so that they can better say what they're feeling and experiencing so that we can help them be more adapted into the educational environment. At the secondary level, we provide a range of services, and certainly this is not all of the supports that are going on in CPS and doesn't cover all of the needs that we know that is out there. So of those, we're going to talk a lot about CBIS, which is Cognitive Behavior Intervention for Common Schools. I'm sure all of you guys know about that one. Anger Coping and Think First, which are really about emotional regulation, anger management, impulse control. Check in, check out, as Judy just nicely described. We're also looking at what are the restorative justice practices that we need to put in place both at the middle school and the high school level so that our students have a voice and sort of an apology of action. How are they going to take responsibility for what happened and how can they make it right? Again, how do we use those primary prevention skills in a secondary tiered intervention? and also small group SEL skill building. So for some of those kiddos who might be doing second step, who may not get the lesson in a large group setting, they may need some additional support. How can we do a small group sort of pre-training for those guys, pull them out, let them be successful because they've already experienced that lesson, so when they're doing it as a large group, they can actually be leaders in that, or reinforcing those skills through sort of lunch bunches or breakfast clubs or a lot of other ways that schools are doing that work. At the intensive level, we are doing functional analysis of behavior, which we discussed earlier, crisis intervention, and this is again where we too are relying a lot on our community partners. So how can we link our schools with their neighborhood communities, mental health agencies, and also, as you'll hear about in this project, we're bringing our community mental health agencies into schools, which increases access to kids, it increases their ability to meet kids where they are, and also to help teachers and families analyze the skills that we're talking about in the Tier 2 system in a more proactive way. Next slide, please. So specifically, we're going to talk about these small group interventions and how we've done this. And we have not gone to scale. We're in about 90 schools right now. We're working with 47 high schools, and there's probably between 50 and 60 elementary schools that are implementing this or getting ready to implement this through another funding stream. The two programs that we offer at the elementary level are Anger Coping and CBIT. And then at the high school level, we're offering CBIT and Think First. It's actually been really nice to have all of these programs work together because we've been able to cross-train a number of our clinicians. So while they may be doing Think First, they'll pull something from an Anger Coping group where they can reinforce those skills. Generally, these groups involve 8 to 10 students. There are folks who enroll 10 to 12 students because, like many other school systems, we have issues with truancy and suspension. We have kids who transfer in and out, and we want to make sure that the group has enough consistency and coherence to go through the entire time of session. The session numbers range from 10 to 15 or 18. Think First is a little bit longer in terms of how it gets implemented. And in general, the sessions are about 45 minutes of direct service delivery. So that doesn't involve the time it takes to go get the kids and stuff and back off and do some of the pre-planning and post-planning. It takes about an hour and a half, we figure, per session for the clinicians to do this work. In order to do this, we had to do a lot of thinking about what are the structures in place. Referenced in her talk that they have student support teams. We have something very similar to that, and again, we're encouraging them to think about these interventions as part of a range of strategies for students, and also really to make sure that we're looking at both the academic and the behavior so that we're getting the right kids into these interventions. In the next slide, you'll see sort of an example of what the flowchart looks like to get kids involved in these services. And then we'll go back and talk about what we do to have this work happen. One of the things that we have found that is critical to this work is to be very clear up front about what are the expectations of the administrators, who's going to do it, how you're going to do it, how long is it going to take, and what are the consistent pieces of information that we want on all students so that we can make sure that students are in the right services. The way that we have developed our system is that it's both data-driven and either teacher, family, or staff-driven. So anyone can refer a student for support services. To do that, they complete what we call a request for assistance form and an SDQ, which is a strengths and difficulties questionnaire. It is a free questionnaire so that it's easily accessible for our district. They complete that, they turn it in, and then the team sits down and says, okay, this is the beginning. What else do we need to know about this child? And so that we can get them in the right group that will make sense for them. And again, not every student that gets referred is appropriate for one of these interventions, so we have to think that through. There are specific screenings that we're using for each of the interventions, and this does two things. One, it gives us a chance to engage the youth and what they're experiencing and the families, and it also gives us a chance to create pre-post data. because one of the things that is so critical about this work is while we want to do great things for kids, we also have to be able to demonstrate to administrators, families, and funders that the work they're doing is making an impact. So we always sort of have two eyes. Is this the right intervention? Is it helping the student? And how do we demonstrate that it's helping these students so that we can tell this story to keep the funding going to keep our students involved? The students are assessed. Again, the group team meets. All of our students for Tier 2 interventions are required to have parental consent. As you can imagine, that can sometimes pose a challenge. As we work with our families, we're getting pretty creative about how we reach out to them, educate them about these services and support, and make sure that they are aware of what it looks like, sounds like, it feels like to be part of this group, and then the family's consent. We do also ask to sign an assent, so that they, again, are saying, yes, this is something I know what I'm getting into, and I'm willing to commit to what this work looks like. The students who don't fit into this, we either identify appropriate services and supports within the school building, or we'll look to our community mental health partners to help us provide additional support if it's a family-related issue, if there are issues that are not appropriate for handling in a school-based setting. We frequently don't address sexual abuse. We will refer that out as opposed to addressing that in a school-based setting. We'll begin the groups, and then we will complete the post-test assessment. In an ideal model, we complete the post-test right afterwards, and then we do try and do follow-up again at 3 months, depending on our capacity. That sometimes happens, and it doesn't always happen, but we always try and get pre-posted. Next slide. The way that we've gone about this is a two-part structure. We have been really lucky in that we have been able to create partnerships with community-based organizations as well as our school-based clinicians. And this has been a really nice model for us because it has built capacity on both sides. There are approximately 300 or so social workers who serve all of those schools and all of those children in CPS. We've also reached out to school counselors and school psychologists, but given their caseloads, they often don't have time for some of the legwork and training. Our CBOs have been great about coming in and partnering with us and being able to help move this forward. We've really created this formalized structure of student identification, screening, and treatment. This has been really important for a couple of reasons. One is, if we're not really careful, we tend to get the highest flying kids, the kids that are causing the most disruptions in the school. I mean, I think we all know who those kids are. The ones that come to the mind when the administrator says, oh, great, you're going to put a Tiger group into our school. And there's a lot of re-education that has to go on about who is a Tier 2, who needs a Tier 2 service versus who needs a Tier 3 service. And so we've had to be really clear about that. And by having this very clear structure, that's helped us be able to be clear about why one student may or may not be involved in this group and what it's going to take. We have tried to build in, Dean's point when we began, a lot of coaching and support. And we are very grateful to Audra and her team and Children's Memorial Hospital because they have been instrumental, as have the developers of the other programs, helping us think through what is the professional development that it takes to change practice. So it's one thing to say, here are the strategies and supports, but what we're really asking to do by using evidence-based practices and manualized treatments is to change the way a lot of folks have been doing clinical practice in our schools. And so in order to do that, in addition to training them on the actual intervention, we've built out 2 different kinds of support. And I think this has been instrumental to our success, and I think will be instrumental to our sustainability. So everyone who is involved in implementing a Tier 2 intervention of the 3 that we mentioned is invited to and strongly encouraged to attend what we call BTAS, Behavioral Technical Assistance. We meet twice a month for an hour and a half. At that time, we have clinicians who have previously implemented these programs, as well as some of our community mental health partners and Children's Memorial Hospital leading these discussions. So it's a chance for them to come together and say, all right, where are you on the implementation? Here are the next set of the skills that you should be practicing. What barriers have you run into? What opportunities do you need to practice? And so they have that time by intervention. And we break out high school and elementary because there's some pretty different issues about scheduling and the actual intervention. What we've also done is build out a systems technical assistance piece, and this has been equally important as we've brought in our community-based organizations and we build these relationships across school mental health people and community-based organizations. We have put in what we call specialists who help be liaisons in that. So we've had to build systems support and clinical support to keep this work going. Next slide. Some of the factors that I think are helping us be successful right now, and hopefully will keep this project going long term, is that we build a common data system. And this data system is a locked data system, but anyone on our CBS site can access it. So that basically all of our data is stored in one core database. You can pull out how many kids are in the group, when are they coming, what were their pre-tests, what were their post-tests, and so that it's a way of communicating and it's a great data access system. Another critical factor for success is really constant communication back with administrators, topics, and families and staff about what we're doing. Because oftentimes mental health services are sort of like the black box. They pick up these kids, they take them for 45 minutes, and they bring them back. But we don't talk about what are the skills and strategies that we're trying to build so they can reinforce those in the classroom. And each of the interventions that we have actually have classroom pieces, family involvement pieces that we really push on so that people are aware of what we're doing. Another key piece to our success, and one of the biggest barriers to implementation, is the rotation of the schedule. As you can imagine, in high schools, getting groups of 10 to 12 kids all together with trying not to hit core academic subjects and rotating them through so that they're not missing too much of time can be quite a scheduling feat. We've gotten pretty good at it, but it's certainly something that people have to be really aware of. We can't just pull kids out of our classes, given A, where the funding streams come from, and B, the importance of academics for our students. I think that we've talked a lot about the fact that these tier 2 strategies are so much more impactful when we have really good tier 1 strategies in place. For example, in schools where we have both second step and anger coping, they're able to use that same language so that they can reinforce what they're learning in their classroom in those small groups. And we've started with the beginning with the end in mind. So recognizing that any large urban school district has a lot of transition and a lot of turnover, what was going to be our model to keep folks in place? So we started with a TOT model, and again, Audra and Sharon and the folks with CBITS have been great, and Think First and Anger Coping, so that now we're building our own cadre of trainers so that we don't always have to bring in the national trainers, which has been good for a couple of reasons. One is it shows the folks in the district that people just like you are doing this work. The second is it saves us a lot of money, and we can offer more trainings because we have in-house capacity. And the third is that it adds a sense of sort of legitimacy that the district supports what the district is doing, and that's been really powerful. They've also had CTAT facilitated by the commission, and everything we've done we've tried to put online so that if anyone out at one school and they're facilitating, they don't happen to have their manual with all of the tools that we've created for them, they can go online and download those. I want to be aware that I have about 2 minutes left, so I'm going to move on to the challenges of implementation. And there are challenges. Obviously, all of you guys who've done this work can know that this is a challenge to Tier 2 work. The co-facilitation model with a community-based agency and the school-based mental health person is both an asset and a challenge. It's a scheduling challenge, and sometimes a personality challenge, but it's also created an unbelievable rich partnership. As the school people tend to orient a little bit more about what is it like to work in schools, and the CBOs bring their own skill sets to the table. Administrative buy-in, it's interesting that we still are doing a lot about what is the impact on trauma. We've had to do a lot of educating for our teachers, staff, and our families as well about what does it mean to have been exposed to trauma. What does that look like long term? How do you sort of recognize that in our students so that we get students that have been witness to violence or trauma. They don't often, sometimes our teachers don't know, sometimes our kids don't feel comfortable talking about it, so we've had to do a lot of normalizing about that work, make it okay to talk about and get the referrals to get into the group. Scheduling and attendance, I think, is a big issue for us. Again, as we're talking about those kids that are the most likely to get suspended because they have anger issues, we've had to do a lot of work with administrators sort of saying, can you not suspend these kids for the 10 weeks or the 12 weeks that they're in their intervention so that they can actually have enough dosage of the intervention so that they can have the skills. And we've had to do a lot of really innovative problem solving with administrators to say, okay, what could you do instead if the student violates the code of conduct so that they can stay in their group? We've had to also talk about change in practice. And I think that's what this group has done a lot of, is that we're asking people to do tier 2 work, tier 3 tier work, and really all of the tiered work in a different way, making sure they're implementing with fidelity. We have fidelity forms for each of the sessions so that they can know that they're following the manualized intervention the way it's supposed to be implemented. And we try to create as many user-friendly tools, but that's a very different practice than we have had in the past. And then, of course, keeping the money going so that we can continue to train, buy materials, keep the folks coming in, and continue to have innovative partnerships. But in general, I think it's been a great opportunity for our district. A lot of students are getting services and supports they may not already have, and we're learning a lot about how to begin to go to scale on evidence-based practice. So with that said, I'm going to turn it back to Kelly.
Okay, thank you so much, Jean and Judy and Jennifer. That was really excellent. Such a wealth of information you all conveyed both in Chicago and the Worcester Public School System. So thank you very much. We are right on time, right on track. So we're going to transition now into the question and answer portion of today's events. Again, for those of you joining us via the web, you may ask a question by clicking on the bubble icon in the upper left corner of the screen. And for those of you joining us by phone, you can send us an email at question@nctsn.org. And I've been surveying a few questions that have been trickling in. I think I'd like to start with, we have a question here from a school principal, and they write, as a principal, I struggle every day with getting my teachers on the same page regarding responding to student behavior. Do you have any advice for me as a school principal? And I think I'll just open that up. Do any of the presenters like to address our first question?
Well, I think it's something that I alluded to, and we know that administrators struggle with this greatly. I remember sitting with a middle school principal when we first had our office discipline referral our database set up, and she was reviewing office discipline referrals disaggregated by faculty, and going through, there were just such huge discrepancies, and you know, it made it very clear that certain teachers needed a lot of coaching, classroom management strategies. It also speaks fundamentally to the need for some sort of consistent criteria. And what we do when we speak to a principal in our district about whether or not they're interested in discussing the positive behavior support initiative in their building, we usually talk with the principal about it a little bit, and the principal will say, yeah, come on in and talk to us at a faculty meeting. And we'll do a little overview at a faculty meeting, and then we go away and let that faculty kind of thrash it out themselves and talk about the benefits to everyone. And what we've asked for so far in our we're implementing in about 27 schools right now out of a total of about 40 schools. We don't have a high school yet. We have some high schools interested, but there's a lot of challenges with high school. And what we ask for is an 80% buy-in by faculty in agreement to look at this, so that there's still going to be a few naysayers there, but a majority decide to buy in. And I think the exciting thing is that when we roll out the school-wide, the universal expectations, people see a real difference. And in some cases, that's meant that some of the faculty eventually say to those naysayers who don't believe this will work, they say, listen, you're undermining the work the rest of us are doing. So it's certainly a large challenge. I think probably the best thing to do is to sell it to your faculty in terms of what's in it for them. What's in it in terms of lost instructional time. Generally, the kids who are sitting at the office waiting for their disciplinary consequence are the kids who can least afford to miss any instructional minutes. And so having that conversation around why don't we adopt a school-wide criteria for what's going to be managed in the classroom and what's going to be managed at the office, and get into that conversation, but with the offer of additional classroom management support as far as skill development for teachers. I know I've been involved in some of that in my district over the years when we've had kind of the career-changing program for people who want to go into teaching in mid-career. We did some after-school groups and talking about classroom management strategies, and more importantly than that, developing mentorships between newer teachers, less experienced teachers, and veteran teachers who have some very good classroom management skills, so that those relationships go on long past any training. A couple of ideas.
I would add to that is that the training program and materials that have been set up by George Sagai and Lucy Lieber in Illinois and people across the country has become very sophisticated over the last 10 years. And there is a whole set of grids and exercises and checklists that are included as part of the training. And several of them deal with how you get a staff working across a school to come up with a grid that, on one side says what the expectations are likely to be, and if we're talking about consequences, what those are. But as a general process, there's a kind of an exercise, a checklist that's part of the training, and then the leadership team that's trained as a part of the PBIS for each school is then charged with coming up with a strategy for going back, getting the staff to kind of reach some kind of consensus on this, and then the administration to accept it. But rest with, because there are now 14,000 schools that are implementing PBIS nationally, have a pretty rigorous step-by-step way of getting consensus. So,
behavior is one of the most common complaints of teachers dealing with their effectiveness. It's these students and their behavior. It kind of turns that on its end when you say, what about us? What about our behavior? Do we really have consistent expectations? When we engage a secondary school staff, for example, in what does on time to class look like for you? And it's kind of an eye-opening exercise. You'll see the light bulb go on all over the room as people realize, gee, there are subtle differences. In general, we know what on time to class means, but when you get right down to ground level, we do have some inconsistent. I expect people in the chair with the book, and somebody else expects them somewhere in the room. And then there's always that good soul who goes out in the class and says, okay, guys, that was the bell, everybody in here. That degree of inconsistency might not upset a kid who's coming to school. When my kids came home from school experiencing those inconsistencies, they would just say, boy, those teachers are crazy. They don't know what they want. A kid who comes into school lacking self-regulation, possibly because they live with some chaos in their personal life or in their community, that kid has more difficulty dealing with that level of inconsistency. That kid tips the desk over and swears at the teacher and gets, thrown out of the classroom for the day. There are huge benefits to being willing to look in the mirror and become conscious of how, what is our expectation, what does that behavior look like, and do we really have consistency?
And to maximize consistency, I'm forgetting now who used that phrase. It was on one of the slides, but it really stuck out to me, how you can maximize, consistency across teacher behavior.
Right.
How important that is.
Mm-hmm.
Yeah. Okay. A similar question regarding initial implementation. We have a question from a school guidance counselor, and their question is, they think PBS sounds exactly what my school needs. Where do I start? Is the question.
The website that Jean mentioned, pbis.org,
Mm-hmm.
is a very good place to start, and depending where you are in the country, there are identified on the map. I don't know if they're in every state, Jean. Do you know if it's in every state now?
I think they now have a contact person in every state.
Oh, wow.
So if you go on PBS and for your state and say there's a contact person, for example, in Massachusetts, it's Martha Wally, who is supervised by Judy. And people call up and say, what do I do? Where do I start? And she gives them guidance.
Mm.
Talk about the local resources and, how to start. And, we have some sort of candid conversations about what's involved with trying to get started.
Mm-hmm.
The interesting thing is, while you need some funding initially in startup, I a few years ago successfully wrote a federal schools counseling grant, elementary schools counseling grant, and we basically described what we wanted to do at Tier 2 with some of our PBIS schools that had a pretty good universal implementation going on. So they had a good foundation, but what I saw and what we struggle with, because Jean talks about 2 to 3 years to get an intervention well established. Yeah, that's given that you don't have principal turnover and faculty turnover and schools being reconstructed under the whole AYP formulas and whatnot. And those are all realities we're dealing with too, which clearly make it more challenging to try to get this sort of an innovation in place. But when we were successful with that, we wrote that grant to talk about Tier 2 interventions as ways of providing embedded mental health support. And we were successful, not in round 1, in round 2. And so we had some funding for additional external coaches, which were some of our school adjustment counselors with a lot of training in Tier 2 and Tier 3 interventions. And we worked with, by the end of it, a total of 24 of our PBIS schools to help those staff in the schools get more efficient, more quick at putting us. So you need some startup money.
Mm-hmm.
At this point, we have enough internal training capacity that we're taking on 1 or 2 new schools each year, and we're training primarily with some internal sources. We when we get other sources, we sometimes bring in the expert trainers for an outside voice that wants to start up. But on the most part, and then through some partnership with the grant Jean's been involved with most recently, Central Mass Communities of Care, we have some sharing of resources through that as well that we can use. But once you get an internal capacity for sustaining and maintaining this, it isn't really funding dependent, or you can direct funding streams that are addressing the needs of kids with behavioral and mental health challenges. You can direct them towards this sort of an implementation, I think.
Mm-hmm. If the funding is available, in an ideal situation, do you recommend implementing PBIS, K through 12 simultaneously, or school by school, or what's your recommendation if the funding is there and secured?
In our experience, I don't know if it would match Jennifer's experience, but she's got a whole different scale of system she's dealing with. We've only done it school by school. Each school is its own little community, like its own family. I think school by school is the way to go. I know that some high schools that have implemented have done, say, just 9th grade. But that would really depend on the structure of that school, because you're not going to get the benefit of the school-wide common areas that are shared by all grades. If you have a separate 9th grade academy, maybe that's feasible, but, it's it's a subject of some ongoing conversation with some of our secondary schools, schools in particular. 3 of our 4 large middle schools have implemented PBIS. And there are always challenges with that, but I think school-wide has to mean school-wide for maximum effectiveness. Some schools that initially were trained and teachers adopted a lot of the practice, but then we had a principal change, and the principal came in and said, I want to do my own thing here, which was very tough on morale because a lot of teachers a lot of faculty and staff had invested a lot of effort in getting the system, the infrastructure in place. But what we found is that sometimes the system kind of hangs on in a not quite as effective fashion, but sometimes the system hangs on, and eventually some principals come around to saying, let's try that. And so it's been easier to resurrect in some of those buildings than in others. So it really depends, but I would say, school-wide is for maximum benefit, for sure.
The training tends to be, if you look sort of at the last 30 trainings that were done across the country in PBIS, there's a certain economy of scale that tends to apply because trainers probably are something like $1,500 a day. You need something like 6 training days in year 1 to implement at the tier 1 level. And so when you figure in what it's going to, a training site, trainers, materials, whatever, I think the clustering is somewhere around 6 to 8 schools at the low end, and I've seen as many as 30 schools at the high end can come together and be trained at the universal level at least. And so if you do it that way, if you figure out economies of scale, it would be kind of hard for a single school starting from scratch to bring in a trainer for 6 days, $9,000 in year 1. But if 6 or 8 schools, either in a single district or across multiple districts, were to come together and share the costs, it actually becomes quite economical. And it's a one-time sort of thing. When you get to the tier 2 and tier 3 level, it's a different approach, and it's more specialized, and it's for a narrower type of counseling, psychology, and whatever. But at the universal level, if you're really starting from scratch, you would need to think about economies of scale. By the way, the website, if anyone Googles PBIS, you'll come to pbis.org, and it's a very user-friendly and very rich website, and you just pose the questions, where do I start? And there will be a section on that. There's a whole blueprint that tells you from A to Z how to implement PBIS with all the principles and the refrigerator magnets and everything. Totally free. The website charges for none of the materials that they make available. So in terms of getting started and coming up with a plan and figuring out what do I do if I want to do PBIS, that would be the place I'd go and spend a couple of hours over a couple of days, and I think most of the questions will be answered.
The increased awareness of the need to have interventions to prevent bullying is another selling point for PBIS. Everything you read about best practices in the prevention of bullying in schools is a school-wide system, a tone and a culture that teach everybody what's expected behavior and that bullying is not okay. So that's one more kind of selling point. I don't know if there's funding attached to that in some states. In Massachusetts, we have a new law that we're all obligated to be implementing, and we're working on that. But a school-wide system is certainly an advantage in trying to combat the bullying, which is very high profile lately.
Okay. Well, there are 2 more questions, and we have just a couple minutes. 2 more questions that I'd like to throw out there. So quickly to our presenters, we have a question here. Can PBS be used in the IEP process, specifically to set IEP goals? Do any of you have experience integrating PBS into the IEP process?
I think I think that the IEP process, and Jennifer is housed within a special education division, so she can correct me if I'm wrong.
Mm-hmm.
I think the IEP process is so highly regulated and specific. I think in terms of building in goals around behavior for students who are on an IEP, either to encourage the development of certain skills,
Mm-hmm.
teach a competing and more functional behavior to replace an unacceptable behavior that student may have, that's appropriate. But the IEP is focused on the individual student, so the IEP doesn't create the context in the classroom or in the school. The IEP in itself doesn't create that, but as part of an individualized intervention for a student, certainly, some aspects of that individualized intervention may be on the IEP, but the IEP in and of itself won't be sufficient if you don't have everyone who interacts with that student
Mm-hmm.
building in. Do you have more to comment on that, Jennifer?
I would agree with you. I'd say that the strategies and supports of PBIS, especially at the universal level, are really there to help that child be successful in meeting their goals of their IEP, but I wouldn't say they're synonymous with those goals. So that really that those strategies are there to help the child scaffold, but those goals should be written independently for a child to help them meet their individualized.
Mm-hmm.
Use some of the strategies and support to help them get there, but I wouldn't write them in as the goals.
Mm-hmm. Okay, great. Thank you for clarifying that. Okay, our last question. Do any of the presenters have experience implementing PBIS with school-based police officers?
We actually, when we train our folks in Chicago, we do a lot with our school security folks because they set the tone for our kids, and so we work really hard to include them in the trainings. We've actually had them have their own breakouts where they talk about what are the expectations so that they can post for kids coming into their school building, what should it look like when you come in. We've done a lot to help them understand about proactive and reframing the way we expect kids to behave and how to teach them and greeting. So we've done a fair amount of work with our school security guards around this work.
Mm-hmm.
Really impactful in those schools that have embraced it because, again, they set the tone for how our kids enter our school buildings every day.
Mm-hmm.
We don't have school police officers per se, although there are some school liaison officers, and some of those folks are very high status individuals for certain kids.
Mm-hmm.
So sometimes they have been built in as kind of a person who's less formally, but who agrees to sort of check in on a kid weekly or something like that, just because it's a very reinforcing contact for a particular student. Really benefits from that relationship.
Mm-hmm. Okay. Well, we are out of time. I want to thank you so much, Jean, Judy, Jennifer, and Audra. Would you like to make any closing remarks or anything still on your mind you'd like to share?
No, thank you very much for this opportunity. It was very nice.
Thank you.
You're so welcome, and it was just a pleasure today. Thank you also to our audience for joining us, and just a quick reminder to everyone to please hop on and complete the post-presentation evaluation. And then lastly, I'd just like to remind everyone that our 5th and final Schools in Trauma webinar is scheduled for Wednesday, February 23rd, right around the corner. The title of this our last webinar is Trauma-Informed IEPs, Differential Diagnosis and Trauma-Informed Assessments in Schools. We hope you'll all be joining us again, and please visit us at the course homepage on our Learning Center for any more information you'd like about the Schools in Trauma webinar series. So again, thank you so much, and everyone have a good day.